Today on the 229 podcast.
We're wearing a new hat in IT because none of the healthcare IT team members that I have today came to healthcare expecting to create automation that's really a warehouse, akin to some of the automation that Amazon or UPS would see.
My name is Bill Russell. I'm a former health system CIO and creator of This Week Health, where our mission is to transform healthcare one connection at a time. Welcome to the 229 podcast, where we continue the conversations happening at our events with the leaders who are shaping healthcare. Let's jump into today's conversation. Here we are. It's the 229 podcast, where we continue the conversations that start at the meeting. Today, we're joined by Tricia Julian, CIO for Baptist Health. I should say the Baptist Health in Kentucky, because there's so many Baptist Healths around the country. And Nilesh Desai, Chief Pharmacy Officer for Baptist Health. How do you guys distinguish yourself? Just start there. How do you distinguish yourself as Baptist Health? Because there's a number of them.
We just say Baptist Health Louisville, Kentucky.
There you go.
Or Baptist Health Kentucky and Indiana, because we have locations there too.
I'm going to try to get this, the Baptist Health, to stick. You ever hear him say the Ohio State University? That's
Yeah.
Yeah. We're going to continue a conversation that started at the 229 Project, which was really fascinating. And it's on Central Pharmacy Services Center that you guys stood up. And Nilesh, I want to start with you. What prompted the decision to invest in a 102,000 square foot Central Pharmacy Center at this point in history?
When I came to Baptist, one of our, opportunity, I call it, I started during COVID time. So the first year and a half was like, okay, how do you survive with everything that was out there? But during this time, it took me about 6 months to assess the gaps, what are we doing? What are we not doing? And we had retail pharmacies at some of our hospitals, but not at all our sites. And then specialty pharmacy and inventory management, call center, you name it, and the things that we didn't have in place the way we should, or many health systems have, that are out there doing it. And, about 10 years ago, I actually had a vision building out a central services center for, systems that have 7, 8 hospitals or more, to really leverage and create a centralized process where you can be a lot more efficient. Now, if you think about from a, there are many aspects to it and the industry challenges that are out there. So if you think about, staffing shortages, for the last 15 years, we've been battling pharmacy technician shortages. Very dangerously post-COVID, we're actually battling pharmacist shortages in some markets now. And by 2030, you're going to experience a lot more pharmacist shortages. Mm-hmm. And then we already had drug shortages. 20, 30 years ago, we used to have 30 drugs in shortage. No one felt an impact. But now when you have 200 and 300 drugs on shortages, it becomes an operational management issue. How do you manage your drugs? How do you manage certain things where care is being provided? Medication access becomes a larger issue for us. And I don't know how many headlines have you seen, but a lot of chains are not closing stores on weekend, or they are closing their stores early in the evening. So now our patients, when they leave their emergency room at 7, 8 o'clock in the evening, there are no pharmacies open. So how do they get their medications? As a lot of independent pharmacies were starting to fold up because of the reimbursements getting tighter, they couldn't even keep the lights open. Mm-hmm. So when you start putting everything together and, the same issues resonate with Baptist, opportunity was there, challenges were there. How do you take this to that next level of what a pharmacy should look like? So I'm part of this Omnicell board where, we kind of designed this autonomous pharmacy workflow, I call it. So it's 5 levels where you assess your health system and then you kind of say, okay, I'm at level 3. So when we did that exercise at Baptist, we were around 2.9. And then I said, well, we need to get closer to that 4.5 level where you have technology. And in order to do that, you really have to be brave enough to go explore other industries, because supply chain has done it. So we started exploring. We went into UPS, we went to Cardinal, we went to Medline, we went to Amazon, we went to many other health systems. There were other health systems that were doing some type of central pharmacy, but not to the level of automation that we wanted. So we really, we talked to many vendors. We settled on 8 vendors. We had an 8-way NDA done between Baptist and all the vendors. So
Yeah, I'm looking at this partner list, this vendor list,
yeah,
and I recognize I recognize three out of all of them. So Tricia, he threw this
That's it.
curveball to you and said, all right,
yeah,
here's what we're going to do, make it all work.
Here's
yeah.
our vision. And so I love though, Bill, because the fact that you said when you looked at it, you said, I recognize three. That was my exact feeling. And so, what's interesting is the pharmacy IT team, right? Partnering with them, pausing with them to say, this is going to be brand new for us, for all of us. For Nilesh and his team, they've never done this. The vendor partners have never done this. We've never done it. So what we're going to have to do is enter this space, recognizing we're going to have to be really intentional about communication.
Right.
And we're not going to have anyone else that's done it before in healthcare this way that we're going to be able to call. So again, we are going to have to be unafraid to ask questions, many questions, put the flag up if something doesn't feel right, doesn't look right, do the pauses. So it's been a journey.
You guys are going to educate me. I've joked over the years that this is the education of Bill Russell. So drug shortages, tariffs, staff shortages, pharmacy deserts. I mean, these were some of the things that you touched on earlier. Is this just as simple as saying, for the state of Kentucky, we have one highly automated pharmacy that's doing a series of services, and we have a distribution mechanism to all of our remote locations? Is that oversimplifying it?
Actually, yeah. I mean, if you think about this, was kind of designed for Baptists. So if you think about the inventory that we have from a Baptist perspective, we have 8 hospitals, we have 12 retail pharmacies, we have close to 450 plus clinics.
Right. And this covers pretty much the whole state, right?
This is a good 75% of the state. When you're planning a center like this, you have to plan a lot of logistics around it because you have to obviously deliver these drugs. That's just one component from an inventory management perspective. The second business component was prescription fulfillment. We were not capitalizing our prescription fulfillment the way we should, even when it was our own employees. They would go to CVS, Walgreens, whatever, and then all the same issues with pharmacy does it, etc. So we started to, put in where you have to come to fill in your meds at our own pharmacies, whether you're at the hospital or, and then sent as a local pharmacy started to max out, they didn't have space to grow. So that's when the idea for a central pharmacy came into play.
How many pharmacists are involved? Are they actually at the center, or are they located?
Yeah, so at the center on the inventory side, there's 5 pharmacists and about 14 techs. And then on the fulfillment side, there's quite a few more pharmacists and techs because there you're doing a lot more volume. I mean, we started with 50 scripts August 12th of last year, 2024. And a year later, we're filling 3,000 scripts a day.
You have community pharmacy fills here. I'd love to hear the metrics on, they'd walk out of the hospital, walk past your pharmacy and go to CVS and get it filled. Has that number changed?
Yeah. So again, 6 years ago, our meds to beds ratio was around 15 to 20% at best. Today, we are hovering around 40 to 60%, depending on what hospital. My goal is to get to 90%. So when patients will go home, they should go home with their medications. Now, that's only possible if my volume at the retail pharmacies is, lesser, so they can manage this increased volume and central pharmacies filling the stuff that they need to. So all your maintenance medications come out of central pharmacy. So now they can work on the one-time fills.
So do you need less pharmacists? I mean, you talked about the staffing shortage. Do you need less pharmacists as a system?
It's almost as you increase the volume, you're going to need more pharmacists.
More pharmacists. It's like
you're building your volume up, right? I mean,
right.
We fill 10,000 scripts a month, to now we're filling 90,000 scripts a month. So obviously, you're going to need more people. But it's not vis-a-vis the same number because now there's technology in place. If we didn't have robots, we didn't have any of that stuff in place, you would have to have a large number of people. But because of the technology aspect, now the numbers are lesser.
Flipping through these pictures of this center,
Yeah.
This is not technology that I ever had to deploy. So I'm glad that you did it, Tricia. What did you learn in this process of deploying? I mean, this is serious automation and equipment in here.
It is. What I remember saying to some of the executives that I report to, CFO, COO, was I was just reminding them that we're wearing a new hat in IT because none of the healthcare IT team members that I have today came to healthcare expecting to create automation that's really a warehouse akin to some of the automation that Amazon or UPS would see. And so, what was familiar to us was Epic communicating with Omnicell cabinets. That happens in the hospital. That's familiar. What wasn't familiar is now we're going to collect all that data from what's going on in the hospital cabinets throughout Baptist, and we're going to send that information to the CPSC. And then that data is going to convene in a couple of different products, vendor partners that are in the CPSC so that the inventory replenishment happens automated. And so all the picks of the meds are starting with robots and it's automated and things are running along conveyor belts so that then it gets packaged. And then when it's packaged, it's again, that's all automated. Nobody's touched it. And it's figuring out which of our hospitals that package now goes to. And then everything about what's in that package has been closely identified. So we know exactly what's in it, down to the PARs, down to the NDCs. It gets shipped. And then when it gets on the other end, it gets received. And so now, again, how do we have the right sort of communication in mass occurring back to CPSC so that everything is right about where all the controls are in terms of the inventory and where it stands. And then all the financing, so all the necessary ledger, accounting for all those activities was also new to do it in that type of in mass replenishment activity. And we're live everywhere. He's replenishing all of our hospitals with these tools today.
It's wild. Did you have to work with Epic to do some things they hadn't done before?
We did.
Yeah.
So the good news is that's where there's a powerful synergy that did evolve between the expertise within Nilesh's team, much like we were talking, he has pharmacists on his team. I have pharmacists on our team. The IT team has pharmacists. So they're talking a common language in that regard because they all are pharmacists. And then they're working with the vendor partner. So with Epic, yes, there was a pharmacist on our side who was able to say to Epic, here's what we need. Here's where our gap is, and we're going to need you to help lean in. So there was some development for sure on the Epic side.
Which stakeholder was hardest to win over to this vision, this concept? On the deck, it says better for patients, better for physicians, and better for the hospital. Was there a stakeholder that was harder to win over than another?
I don't think that was an issue because I think the way in this was pitched, it was about, from a community perspective, having medication access. Surprisingly, we had a 93% retention rate. The patients, once they came to Baptist, they didn't leave Baptist. They said, we like the service you're providing. So that gave us that additional arm to say, all right, if this is at this scale, if we're able to retain our patients, then imagine if we roll out to 40, 50 clinics. Now we can be talking different numbers altogether. And that's where, the process started.
The proof is in the pudding. So I don't know where that phrase came from, but anyway, metrics. So what key metrics define success for this program at this point? Nilesh, I'm curious what the outcome has been.
So outcome wise, if you think about, we were 5.5 years ago, we were at 10,000 scripts a month. Today, we're filling close to 90,000 scripts a month.
Jeez,
so
that's amazing.
Yeah. So incrementally, it's, ability to negotiate better pricing, providing better costs to our patients. Because if I'm able to negotiate better pricing, why am I not going to provide that to our patients? So this, scaling down from a health system perspective, we're self-insured. So, there is a way you can manage pharmacy benefit management. From a health system perspective, the second largest expense, it used to be medical benefits, but now it's turned around. Your second largest expense is your PBM. which is your pharmacy benefit. So how do you help manage that? And then if you have better controls in this place, and then you're able to control costs, which indirectly benefits the health system, especially when you're in a zone where cuts are occurring, Medicaid cuts are occurring, tariffs are coming on board, so one after another, it puts constraints on health systems. So there's a way you have to mitigate, and this is another way where pharmacy can come, step out, and really help the health systems in a very different way.
From concept to build, what was it, about 2 years or a little?
3.5 years from concept, business plan, construction, going live.
Yeah. And the IT work with the design and all of the details there really started in earnest in January of 24. Yeah. And to Nilesh's point, we had a first go live with pieces of it last August, and we're still not finished. We don't really finish all the pieces of the project until March of 26. So yep. IT build intensity has been from January 24 through March of 26.
Well, you may want to get that done, Tricia, because it sounds like, at 90,000 scripts, I mean, he might outgrow that 102,000.
Bill, I hadn't even thought of that. Nilesh, I'm not ready for that quite yet. Expansion of a new facility.
Did you have to build a special facility, or could you just get any warehouse and retrofit it?
No, so we did look for ready-to-go warehouses where you have to do some modifications. But the issue was we couldn't find it centrally located, or it was way too expensive. And fortunately, one of our hospitals right behind that, Baptist actually owns quite a bit of land there. So, they said, hey, you have this property. We don't have to pay for property. All you have to do is you'll get a brand new building. I'm like, all right, we'll take it. So, yeah, it was the ground up, build when we kicked it off, and we have a beautiful building.
I think in these times with Medicaid cuts and other challenges coming down the pike, it's a shame you didn't tell me that, hey, you could stand this up in 6 months. Because
I wish I can tell you. The vision was in the head, but getting people to do what you want is a whole nother thing. And then, especially in the technology world, IT world, it's easy to say, Nilesh, do this, but is it really possible? And, I was tough with a lot of the vendors. I would say, no, I'm not negotiating on this one. This has to flow. There cannot be an FTE here because, my plan was already done. Business plan was already submitted. So it wasn't like, oh, I can go back and add another 40 people or 30 people. That wasn't going to happen. Fortunately, the vendors played the right workflows. They designed the technology as such. We've already had over 35 health systems already come for site visits. There are more coming. Interestingly, I have a lot of pharma companies doing a lot of site visits as well. So, to our benefit, it worked out for us. And now if I have to redesign this, I mean, there are some things I would do a little differently, but definitely I would say, again, it takes a village. It literally took a village to make this happen. I mean, internally and externally, both, to really get this done. But it's something to be very proud of. It's a nice crown that we have here now. So,
well, congratulations. This is a great project and I love the outcome. And Tricia, thanks for sharing. It was early on that you shared where you were at, because it was actually the problem or challenge that you were dealing with. Yep. And you put it out in front of the other CIOs and said, here's the technology stack. And they all looked at you the way I did, which is like, I don't know what that is. Like, good luck.
Yeah. Yeah, there was. Nilesh, you should know. They did say, good luck. And can they really do this?
Can you really do this? That was the conversation. It was like, man, when you're done, let us know, because this looks really interesting.
Yeah, we're at the final pieces of what we have to do. By March of 2026, we should be done with at least 90% of it. And then we have one or two things that we have to do to really get this going. The intent was take it to that maximum level of workflow efficiency. So this way, you're not spending human resources the way you need to. You should have technology do the work for us.
Right. Fantastic. Well, thank you for coming on the show. Thank you for sharing this. Nilesh, Tricia, thank you. Thanks for listening to the 229 podcast. The best conversations don't end when the event does. They continue here with our community of healthcare leaders. Join us by subscribing at thisweekhealth.com/subscribe. If you have a conversation that's too good not to share, reach out. Also, check out our events on the 229project.com website. Share this episode with a peer. It's how we grow our network, increase our collective knowledge, and transform healthcare together. Thanks for listening. That's all for now.